And good afternoon, everyone, and welcome to our Center for Practice Excellence Speaker Series. My name is Zubin Austin. It's my pleasure to be one of your hosts for today. We're very excited about today's session because we are going to be getting the opportunity to hear from the future of pharmacy. We're going to be hearing from two of our MSc PHM students, Maria and Jessica. Annalise will introduce them in a moment. But for those of you that are not familiar with the Masters of Science in Pharmacy degree program, let me just give you a little bit of an update on this. The MSc PHM is a new degree program that is an advanced professional practice experience for pharmacists who already have some kind of clinical experience, and it builds on their entry to practice degree programs. The objective of the program is to educate and train pharmacists with high potential for leadership and a passion for becoming clinical pharmacy leaders and academics. The program provides students with opportunities to gain both advanced clinical and therapeutic knowledge, as well as practice experience in a defined area, in addition to research, education, and leadership skills. And as you will hear today from Jessica and Maria, we're thrilled that we have such great students, and these are our first two students in the program today, who are joining us to share what their research projects are for this. So let me, with no further ado, turn it over to Annalise, who will introduce our speakers, our discussant, and get things going. Over to you, Annalise.
Thanks, Zubin, and I'd like to welcome everyone to today's session as well. It's going to follow a little bit of a different format than usual. So as Zubin mentioned, we'll be having two presentations. Jessica will get us started off, and then Maria will round out the last half hour. So after Jessica's presentation, we'll just be having a live audience question and answer. So please feel free to type your questions into the chat box at any point during Jessica's presentation, and then I'll ask her those questions. After she presents, she can provide some answers to those, and then I'll introduce Maria, and we'll follow the same format of question and answer right after Maria presents. So just to introduce Jessica, in 2003, Jessica completed an Honours Bachelor of Science degree in Human Biology and Microbiology from the University of Toronto, and then went on to complete her Bachelor of Science in Pharmacy degree from the University of Toronto in 2007. Following this, she completed a hospital residency at London Health Sciences Centre and accepted a position at Victoria Hospital as a pediatric pharmacist, and then in 2011 as the pharmacist for the cardiac care unit at the University Hospital. With the hope of advancing her clinical practice and further exploring both research and teaching, Jessica is currently completing her Masters of Science in Pharmacy degree at the University of Toronto with a clinical focus in addictions at the Centre for Addiction and Mental Health here in Toronto. So Jessica will be speaking today, as you can see, about opioid agonist therapy at the Centre for Mental Health and Addiction, the Centre for Addiction and Mental Health during the COVID-19 pandemic. Please welcome me in welcoming Jessica to today's session. Thanks.
Okay, so thank you very much, Annalise, for that very kind introduction. So for today's presentation, I'm going to be talking about my research project for my Master of Science in Pharmacy program, titled Opioid Agonist Therapy at the Centre for Addiction and Mental Health during the COVID-19 pandemic. Sorry. So I have no conflicts of interest and no funding sources to disclose. So I wanted to start by talking about the opioid crisis. So certainly we've been seeing increasing rates of opioid-related harms, specifically poisoning and overdoses. And actually between January 2016 and June 2020, we saw 17,602 apparent opioid toxicity deaths in Canada. So on top of this devastating opioid crisis, we're of course also going through the COVID-19 pandemic at the moment, which itself has had a devastating impact on Canadians who are living with substance use disorder. And in fact, during the first 15 weeks of the pandemic, we saw that there was a rapid increase in the number of opioid-related deaths in Ontario, Alberta, and British Columbia. And this really stimulated the federal government to address the opioid crisis during their fall economic statement, in which they announced that they were going to infuse $66 million between 2020 and 2021 in order to help healthcare workers address opioid use disorder. So how do we address opioid use disorder? So opioid agonist therapy, or OAT, is certainly the main treatment for opioid use disorder. So for those of you who may be a little bit less familiar with opioid agonist therapy, I thought I'd start out with a short vignette just to help you kind of get you oriented to what this therapy is and some of the considerations. So you can imagine that it's back in early April 2020. It's shortly after the WHO has declared that COVID-19 is a pandemic. And later this afternoon, you have a patient coming to visit you, and they've recently been diagnosed with opioid use disorder, where they use street opioids and they inject street opioids as their preference for taking opioids. You know that opioid agonist therapy is the main treatment for opioid use disorder. So as a result, you'd really like to start your patient on one of the two main opioid agonist therapies, either buprenorphine or methadone. However, you also know that your patient has never been prescribed these medications in the past, so you'd like to sit down with him and discuss these medications and some of the considerations around them, especially during the COVID-19 pandemic. So keeping that in mind, I'm just going to highlight give you an overview of this therapy and some of the important points that you should remember if you were going to have this kind of a discussion with your patient. So to start, there are some significant benefits of using opioid agonist therapy. So first of all, it's first line and it's life-saving treatment. Second, if you were talking to your patient, you could explain that it could help, it does help reduce the use of other opioids, and in his case, reduce him injecting his street opioids. As well, it can help to reduce cravings that he might have for street opioids, and as well, reduce the withdrawal symptoms that he feels when he stops taking his street opioids. But most importantly, you would really want to emphasize to your patient that this medication is incredibly important for the most important pieces, that it helps to reduce the risk of any death from opioids, whether it's the street opioids that he's injecting or any other opioid for that matter. So that's a key point. You would then also want to talk to your patient about these two medications that you're considering for them. And so you could start by talking about buprenorphine and explain that this is a newer opioid agonist therapy. It's been on them, it was approved by Health Canada in 2007, so there's a little bit of less experience clinically using it because it's newer compared to methadone. However, that being said, there certainly is evidence supporting that it is effective. And as well, there's a lot of evidence demonstrating that it has a better safety profile compared to methadone. So if too much buprenorphine is taken, for example, or too much opioid, it has a better safety profile. And then when you went on to continue to talk about methadone, you could explain that methadone is actually the traditional opioid agonist therapy that has been used for a number of years. And methadone has, because it's been used for a number of years, there's a lot of experience with its use, and there's also a lot of evidence supporting its effectiveness. But there are some concerns, some considerations about side effects. And the particular one that's concerning is toxicity that could be related to taking too much methadone. So after that, you might also want to indicate to the patient that these medications are dispensed in a different way somewhat from their typical medication. So for example, your patient, he takes a blood pressure medication. So when he goes to pick up his blood pressure medication from his pharmacy, he typically gets a 3-month supply of it. But when he would come to pick up either buprenorphine or methadone, he would get a much smaller quantity. And this is actually for his own safety, as well as for the safety of his family that he's living with. In addition, you would explain to him that it's dispensed it has a different way of being dispensed, and there's different terminology that he might hear the pharmacist use when he goes to pick up these medications at his community pharmacy. So for example, when he goes to pick up the doses, let's say his methadone or his buprenorphine to take home, to take independently, he might hear the pharmacist refer to it as a carry. So a carry is really just a take-home dose. In addition, when he's there, the pharmacist may have him take a dose in front of the pharmacist, and this is what's called an observed dose. So there's observed doses, and then there's carries, which are take-home doses. So those are two things to keep in mind. As well, you could explain that if he had been picking up these medications prior to the pandemic, he would have likely had a maximum of 6 carries or take-home doses that he would be picking up at one time. But now, of course, we're in the pandemic. And as a result of that, there's a bunch of recommendations from Ontario Public Health, such as physical distancing, going to the pharmacy less often, and as well self-isolating if you're symptomatic. So because of these considerations, as well as other recommendations, you can reassure your patient that there's really been a lot of work done in the background to help ensure that the way that this medication is prescribed and dispensed is going to be done in the safest way possible for him. But what I really would like for you to take home as a clinician is the sort of bottom line point is that the most effective way to really treat opioid use disorder is to really have the patient engage with their opioid agonist therapy and have them hopefully maintain on their opioid agonist therapy. Because this is really the biggest way that they can help themselves to reduce the mortality risk that can be associated with taking too much opioid. Oops, sorry. So I mentioned that there's some things that have been done in the background. So what exactly has been done? So there's three key stakeholders that came together. So there's the Ontario Medical Association, there's the Women's College Hospital Medify group of addiction specialists, as well as other allied healthcare professionals. And of course, the addiction specialists at CAMH, they all came together and collaborated to really develop opioid agonist therapy management consensus guidance documents specifically written for prescribers. And in concert with this, the CAMH pharmacists got together and they developed a companion document for pharmacists who need to dispense these medications in the community. So if we focus on the prescriber guidance document, there's many recommendations that it makes, but I want to just highlight two really important ones that I'll be talking about today. So the first is that the first recommendation is that they recommend a decreased number of in-person clinic visits, and this is really to decrease the amount of travel back and forth the patient has to make to their prescriber, as well as therefore decrease the amount of COVID-19 transmission in the community. The second important recommendation is that they recommend having a change in the number of carry levels or the take-home doses that are prescribed based on the individual's ability to manage them safely in the community. So as you may recall from the vignette, I mentioned that a patient could have up to a maximum of 6 carries dispensed at a time. And with this guidance document, it recommends an increase in that number, so up to 27 carries that can be dispensed to again, basically decrease the number of trips the individual has to make to get to the pharmacy to pick up the doses and therefore decrease the number or the risk of COVID-19 transmission in the community. So we want to determine whether this guidance document is important, and in order to do so, we really need to understand the implications of the guidance document. So more specifically, were these recommendations implemented? And if so, what impact did they actually have on the patient outcomes? So our hope is that with this research that we're going to do, that it's going to inform what opioid agonist therapy should really look like, what practice should look like going forward once our pandemic resolves. So the objective of this research project is to assess opioid agonist therapy changes during the COVID-19 pandemic for CAMH outpatient opioid use disorder patients with respect to the nature of the changes as well as the clinical outcomes where feasible. So in terms of the methods, the design of this project is a retrospective electronic patient health record review. It's received Research Ethics Board approval. And in order to determine which charts need to be reviewed, we created a report of outpatient prescriptions of opioid agonist therapy, specifically methadone and buprenorphine, that were written by our CAMH Compass outpatient clinic prescribers, that's our addictions outpatient clinic, between the period of March 1st, 2020 and February 28th, 2021. And in addition, we created a structured data collection form that was really used to help collect de-identified information about opioid use disorder treatment both before and during the pandemic. And I just also want to note that this is just really one piece of a much larger project. We're also going to be looking at emergency department visits at CAMH and how opioid agonist therapy, specifically methadone and buprenorphine, were managed within our CAMH emergency department over the course of the pandemic. However, this will not be discussed today. So today I'm going to be talking about our outpatient piece of the study. So to date, we've reviewed 50 outpatient charts out of a total of 359 charts that our report that I mentioned on the previous slide identified so that we will review. The average age of our patients so far is 48 years old, with the range being between 20 and 72 years of age. We have an equal number of males and females. And in terms of the primary opioid that was used prior to their diagnosis of opioid use disorder, 54% were actually using prescription opioids, 26% were using heroin, and 20% were using fentanyl. The number of years since their opioid use disorder diagnosis was on average 15 years, with the range being between 1 and 31 years since their diagnosis. And in terms of their other mental health comorbidities, 28% had a mood disorder, 48% had a mood disorder, 28% had an anxiety disorder, and 30% had no other mental health diagnosis prior to the pandemic. So then we went on to look at the opioid agonist therapy prescription type before and during the pandemic. So on the left here, you can see that we had an equal number of individuals who were prescribed buprenorphine and methadone. And this was actually done purposefully because we wanted to have an equal number in each group so that we could really trace the trajectory of what happened with these two medications in terms of how they were prescribed and how they were dispensed over the course of the pandemic. And also I should note that these 50 people that we looked at to date, which are just our preliminary results, they also were all existing patients at CAMH, so they were already on buprenorphine or methadone. So during the pandemic, we saw that most people of this group stayed on the same opioid agonist therapy that they were on prior to the pandemic, with only 3 individuals who were more complicated and really transitioned back and forth between methadone and buprenorphine throughout the course of the pandemic for various reasons. We then went on to look at prescriber visit frequency. And just to orient you to this graph, the blue bars represent the prescriber visit frequency before the pandemic, and the green bars represent the prescriber visit frequency during the pandemic. And you can see that overall it was fairly equal in terms of before and during the pandemic prescriber visits. But there was a small uptick in terms of the number of prescriber visits that occurred during the pandemic. And this was interesting to us initially because if you recall back to the guidance document, the first recommendation that I mentioned was they recommended having a decreased number of in-clinic prescriber visits, but yet here we're seeing a little bit of an uptick. But actually this did actually make sense because in fact, 80% of these prescriber visits were virtual in nature. So in this way, the prescribers were actually following that recommendation and implementing it that I mentioned earlier because they were having virtual visits and they were decreasing the number of in-person clinic visits. We then decided to continue on and look at the take-home carry levels or take-home doses that they were prescribed both before and during the pandemic, with the blue bars representing their take-home doses prescribed before the pandemic and the green bars representing their take-home prescriptions during the pandemic for their opioid agonist therapy. And with this graph, I just want to highlight this area on the right-hand side to demonstrate that you can see during the pandemic, which are the green bars, there were a number of people, a much larger number of individuals getting prescriptions for 14 take-home doses or carries and 27 take-home doses or carries compared to what was happening before the pandemic. And so again, you can see that the prescribers were implementing that second recommendation that I highlighted earlier. So they were increasing the number of carries or take-home doses that they were prescribing for their patients so that they would not have to go back and forth to the pharmacy as often and therefore decrease the COVID-19 transmission potentially in the community. But then we wanted to look at these take-home prescriptions a little bit more detail. So what I've done is I've taken our 50 patients and I've divided them into 2 groups. One group being the individuals who were prescribed the same number of carries throughout the pandemic, and the second group being the individuals who were prescribed an increased number of take-home doses or carries throughout the pandemic. And I just want to highlight a few things in this chart, in this table. So first of all, if we look at the individuals who were prescribed an increased number of carries during the pandemic, we see that 14% of this group had an opioid agonist therapy dose increase. And if you think about this, this does actually make sense because the individuals who are more likely to have an increase in the number of carries that they're prescribed, this group of individuals are more likely to be stable, and therefore we would expect that their dose would not fluctuate as much. Then if you look further down in the table at the individuals who had the same number of carries prescribed during the course of the pandemic, we see that 35% of them had a missed dose of opioid agonist therapy, methadone or buprenorphine. And this has well made sense because this is a group of individuals that where their prescriber had decided not to implement that second recommendation of increasing the number of carries that would be available to them throughout the course of the pandemic for various reasons. And as a result, these individuals would have to travel back and forth to the community pharmacy more frequently and therefore maybe have to miss a dose if they had to self-isolate, for example. And in relation to this group would also be the group that would experience their withdrawal symptoms more frequently because the withdrawal symptoms would result from them missing their methadone or their buprenorphine. And then finally, if we then go back and look at the individuals who were prescribed an increased number of carries during the pandemic, 14% actually had a relapse. And so again, this is the group of individuals that are more stable because they're having an increased number of carries prescribed for them, so they're more likely to be stable. So we would expect that they would not have as many relapses, which is what we saw. But there were some patients that did have relapses, but it was a much smaller number compared to the other group. Then we looked at these two same groups, but through a mental health lens. So if we look at the individuals who were prescribed an increased number of carries throughout the course of the pandemic, 41% of them had some kind of a change in their mental health outcome. So specifically, there were 18 individuals who had a change in their mental health outcome. And this change was in all 18 cases, was a worsening of their mental health condition from baseline. So if they had anxiety, it worsened, for example. Then if we look further down in the table at the individuals who were prescribed the same number of carries or take-home doses throughout the course of the pandemic, 23% of them developed a new mental health issue. And this, in fact, there were 10 people who had developed a new mental health issue. In 6 cases, it was anxiety related, 3 cases, it was depression related, and there was 1 person who had an increased craving for opioids. And then finally, we looked at the pandemic-related opioid agonist therapy challenges that were identified by prescribers, pharmacists, and patients. And we saw that there were 8 individuals who had a prescription-related challenge. So specifically, there was 1 prescriber who wanted to implement that second recommendation where he wanted to increase the number of carries that he prescribed for his patient. However, the patient was reluctant to do so because they actually like going to the pharmacy on a regular basis because they valued that social interaction. So he was unable to implement that recommendation from our guidance document. Then there were 2 challenges that were identified that were more related to the dispensing of the opioid agonist therapy. And so an example of this, there was a patient who lived quite a distance from their community pharmacy, and they were nervous about going back and forth to the pharmacy and being potentially exposed to COVID-19. So they had to find another pharmacy that was closer to them and then have their prescriptions transferred to that pharmacy. And then finally, there were 11 other challenges identified that were more patient-related, patient-specific, but most of them were actually related to an inability to visit their prescriber or the community pharmacy in person because they had to self-isolate for the fact that they were symptomatic or maybe they actually had COVID-19. So just to summarize some of the key preliminary findings of this study. So first, we saw that there were prescriber visits. The prescriber visits were actually consistently went virtual. So 80% of them went virtual. So there was that decrease in in-person clinic visits as per the recommendation of our guidance document. The second was there was an increased number of carries that were prescribed. And again, this was in line with the second recommendation to have increased number of carries prescribed for patients where the prescriber felt it was safe for them to manage safely in the community. And again, in both cases, really for the purpose of decreasing the amount of COVID-19 transmission potentially in the community. We also saw that those who were stable enough to have their carries, the number of carries prescribed or take-home doses prescribed, they actually continued to do very well throughout the pandemic, which was encouraging. And those individuals whose carries really did not change in terms of the number of carries that were dispensed throughout the course of the pandemic, this could have been perhaps because they were less stable to begin with, or it might have been that perhaps the prescriber felt that changing the number of carries that were dispensed might have impacted the patient's ability to access their opioid agonist therapy. So you can see that we really still have a lot to do in terms of charts to review, but really importantly in terms of work to do to understand the impact of these changes. But we hope once we do collect more data that our findings will help to elucidate the impact of the COVID-19 guidance document during the pandemic, as well as identify the nature of some of the challenges that were experienced by prescribers, patients, and pharmacists as they all tried to navigate through these changes over the course of the pandemic. And before I finish, I just wanted to highlight that there were similar barriers to accessing opioid agonist therapy that were seen during previous crises over the last 2 decades. So specifically, there was Hurricane Sandy, Hurricane Katrina, and of course the 9/11 attacks. And during each of these crises in history, similar guidance documents had to be created to help opioid use disorder patients access their opioid agonist therapy in the community during the crisis. But what's interesting is that once these crises resolved, all 3 areas went back to what they were doing prior to the crisis. So that leads us to today and what should we really do when our pandemic resolves? So we hope that this information is going to help assist with the reflections on how the changes from this guidance document, how they helped opioid use disorder patients access their opioid agonist therapy in the community, as well as help inform key stakeholders as they plan for opioid agonist therapy access going forward once the pandemic resolves. So really, should we revert back to what we were doing in terms of opioid agonist therapy access prior to the pandemic, as we saw in the last 3 crises of the last 2 decades? Or should we really dig into the outcomes from this guidance document even further to determine whether they were successful and helpful? And if they were, perhaps do we make these more formal and make them guidelines? Or do we create a new set of guidelines that perhaps is a hybrid of what worked really well from our previous guidelines and what's worked well from this guidance document? So certainly this project is not going to answer that question directly, but we hope that the information we gather will help to inform those key stakeholder discussions that need to take place once the pandemic resolves. So these are my references. And just before I conclude, I just wanted to acknowledge Beth Spruill and thank her so very much for all her guidance and support throughout my research as well as the program. And my co-investigators, Dr. Maria Zhang, Dr. Bruna Brands, and Dr. Francesca DiPaolo. As well, we've had two third-year University of Toronto pharmacy research students working with us the last few months, and they've done a lot to collect a lot of the data for both this outpatient piece and the emergency piece. So I want to thank them for all their hard work and dedication. It's much appreciated. And of course, my advisory committee, Dr. Lee Dupuis, Dr. Natalie Crown, Dr. Bruna Brands, and Dr. Beth Spruill for all their guidance throughout my program and this research project specifically. So with that, I'll thank you very much for listening, and I'll open it up to any questions that you might have.
Thanks, Jessica. Fantastic work in bringing together so much timely and relevant data and implications for clinical practice right now. So would like to thank you for sharing your work with us. I'll give people online in our audience just a few moments to type in any questions that they might have, and hopefully we can get to 1 or 2. But maybe just to start us off, Jessica, I know I'm really interested in the fact that you're saying 80% of the visits, I think, were virtual, which I think is hugely significant, but also is very different from the quote unquote disasters or pandemic-esque events that have happened over the past 2 decades. So with that change and then the rise in virtual care, virtual services being offered, I guess, could you speak a little bit to how you see us moving forward with this guidance document in the virtual care space for opioid
care?
Sure.
Thank you for that question. That's actually a very interesting point. And certainly during my clinical part of my program, I was working in the outpatient, the Compass clinic that I mentioned. And I've seen that they were primarily using, I don't think when I was there, actually, I didn't actually have an inpatient interaction. It was all virtual unless there was somebody who was significantly needed to see the physician in person. But for the vast majority of the cases, it was virtual. And I think that that's an excellent way to incorporate that into our practice going forward, because there's certainly a lot of people that they would see in this clinic that were from northern parts of Ontario, who I remember one patient, who wouldn't be able to necessarily easily get down to Toronto to see the doctor. And this would be, open up more access to the physician and to having support if they needed from various, everybody else who was in the clinic, not just the physician, but the pharmacist, the physiotherapist, the occupational therapist, et cetera. So I think it's a real benefit because we've now kind of tested it for a number of months and it's been successful, and patients seem to really appreciate it, that they could easily have an appointment or talk to somebody if they needed, versus having to physically come in directly to have that contact. So I think it's nice to see that it has been implemented, and I think it's certainly, from what I've seen in practice, it's been very effective, and I think it'll open up people's access even further going forward.
Mm-hmm. Yeah, I think that's such an important point, especially as I think it's become quite obvious that there's been variation among the COVID rates across the province, but also the country. So I think always addressing that urban and kind of rural divide will be increasingly important, and virtual care obviously provides a great avenue to do that.
Absolutely.
I don't see any questions online yet, so maybe we'll move ahead. I'll introduce Maria and allow her to present. And then hopefully we'll just have enough time at the end for any questions for Maria's presentation, but also any lingering questions that people might have from Jessica's presentation. But thank you again, Jessica. Fantastic to have you share your work with us.
Thank you for the opportunity.
So our next presenter is Maria Marchese. Maria is a pharmacist who obtained her entry-level PharmD from the Leslie Dan Faculty of Pharmacy in 2015. She completed a hospital residency at Kingston General Hospital and later worked as a clinical pharmacist at the Thunder Bay Regional Health Sciences Center while maintaining a practice in community pharmacy and long-term care settings. In January 2020, she relocated to pursue the Master of Science in Pharmacy program at U of T in adult oncology under the supervision of Carlo De Angelis. Her research project involves investigating perceptions of cancer patients referred for medical cannabis use at the Sunnybrook Odette Cancer Care Center here in Toronto. Maria, I'll pass it over to you, and thanks so much for joining us today.
Hi, everyone. Thank you for having me. I'll be speaking to you today about a unique pharmacy initiative at the Odette Cancer Center, which is the Cannabis Consultation Service. Some of this work serves as to support my research project for the MSc PHM program. I do not have any commercial conflicts of interest to disclose. The qualitative research project for my master's, which I will describe later, has been awarded a research grant from CAPFO, which is the Canadian Association of Pharmacy in Oncology. So today I'll briefly introduce how medical cannabis relates to oncology pharmacy practice. And then I'll walk you through an overview of the program we have implemented at Odette Cancer Center for medical cannabis consultations. And I'll be reporting some of our data that we have so far, describing the population and some basic outcomes. Finally, I'll introduce some current opportunities to continue research in this area. So I just want to introduce what I'm defining by medical cannabis. So the definition that we're using is that this medical cannabis is a plant-derived extract, so not our pharmaceutical synthetic analogs. And we know that cannabis has two main cannabinoids, THC and CBD. And THC is often known for its analgesic, antiemetic, sedative, and muscle relaxant properties, and that's by being a partial agonist on CB1 and CB2 receptors in our endocannabinoid system. And CBD, the other constituent, is a bit more elusive in how it interacts with the system, but is found to have some anxiolytic, anti-inflammatory, and anticonvulsant properties. So medical cannabis has been available to access in Canada since the early millennium. So let's suppose you're a patient taking medical cannabis, just to describe how you would go about getting yourself some. First, you must be authorized to use medical cannabis from a nurse practitioner or a physician through a medical document. And once you have your medical document, you must register with a licensed producer or distributor to order the cannabis. And then finally, the product is shipped out to you. Normally that's the process. So this was last updated in 2016 with the Access to Cannabis for Medical Purposes Regulation, ACMPR. These regulations were incorporated into the Cannabis Act in 2018 with legalization. So even though legalization has led to easier access to recreational cannabis, and remove some of those barriers, the process to obtain medical cannabis is complicated, and it may take at least several days up to several weeks. We have also seen a rise in the use of medical cannabis, particularly in cancer patients. And if patients aren't using it, observational research is revealing that they are certainly interested in doing so. In a survey out of BC Cancer Centre conducted in early 2019, which was 3 months after legalization, it found that 29% of their cancer patients self-disclosed using medical cannabis. I would not be surprised if it is even higher than this now. This increased use of medical cannabis is met with challenges on the health professional side because we have limited evidence. There's not a clear role in therapy, and often patients are relying on other sources for their information on medical cannabis. This recent study speaks to that risk of consumer misinformation, and the misinformation is often inflamed by social media or word of mouth spreading around. So this study, the authors took the top 10 Google hits for medical cannabis and systematically evaluated those website claims, finding that 76% of the claims were blatantly inaccurate or based on very low quality evidence. Most of the information, by the way, was not written by a healthcare professional. So how can we expect patients to navigate this sea of information when health professionals such as pharmacists are not there to provide guidance? And even this on the right panel there, the web article, which Harvard Health seems like a credible and unbiased source, it's plagued by unsolicited commentary from unqualified individuals that may misdirect patients and lead to misunderstanding. Lastly, in a Canadian survey from Abacus data last year, we're told that patients need support. Most respondents in this survey perceive that it's difficult to find a healthcare practitioner to speak about medical cannabis. And this speaks to the stigma around the topic. And then 83% of the respondents went on to feel that medical professionals have stigma towards medical cannabis. So this might be a good time to ask yourself, how comfortable are you with speaking to your patient about medical cannabis? So let me introduce you to our cannabis consultation service. When oncologists at Odette Cancer Center expressed a need for assistance with medical cannabis, Carlo DeAngelis, my supervisor, started providing consultations led by the pharmacists and master students. Currently, we receive approximately 1 referral per day, business day, and our primary function is to conduct patient assessments, provide recommendations regarding appropriate use of medical cannabis, and supporting the patient through obtaining their authorization, registration, and dosing. Promoting safety is our #1 goal here, but we also aim to work with the patient to achieve their treatment goals. So this is an overview of how the service works. Patients can be either referred by their oncologist or another health professional at Odette Cancer, or they could be referred by someone in Odette Pharmacy, or they might even come to us and self-refer. Then we will set up a time with them to conduct our initial assessment, usually over the phone. As part of the initial assessment, we collect their medication history, perform a drug use and abuse screen using the TAPS tool, and we also ask about their previous use of cannabis. To assess global symptoms, we use the MSAS, which stands for the Memorial Symptom Assessment Scale. And then we check always for potential drug and disease interactions with cannabis and assess all of the therapeutic alternatives for that patient. The case is then reviewed with the more senior pharmacist, and there may be additional symptom-specific assessments we would perform. These include for insomnia, anxiety and depression, and I would say most commonly pain. The assessment is then documented in our chart, which is Mosaic and SunnyCare. We discuss our recommendations to the patient, and if medical cannabis is suggested, we would obtain the medical document for them and provide the patient with instructions on how to register and order the product. Follow-up is a very important component, and it usually also occurs over the phone. And we will provide dosing guidance on the cannabis and always proactively monitor the patient for adverse effects at regular intervals, and also for potential symptom improvement. And I would like to highlight it's a comprehensive assessment. So not only are we assessing for potential medical cannabis use, if there are other appropriate therapies that the patient may benefit from starting or stopping, these become part of our recommendation. We really use this opportunity to optimize current pharmacotherapy for the patient, identify drug-related problems, and counsel on adherence if that's also an issue. If there are multiple symptom complexes, we may prioritize and evaluate those that are the most bothersome to the patient. And I would like to also mention, we do prefer to use validated scales, as this provides a standard assessment of the symptoms at baseline, and we can then repeat those scales later to determine if there's any interval improvement. We have noticed and acknowledged that administering multiple long extensive scales is not the most patient-centered approach. As a result, we've moved away from relying so heavily on the symptom scales if they're burdensome to a tired patient. So some scales are available as short forms, and so we have recently switched to a short form of the Memorial Symptom Scale, and I tend to do my own modified brief pain inventory, which is a little bit shorter. So this is just a few examples of the scales I've been speaking of. The Memorial Symptom Assessment Scale is more of the global symptom assessment tool. We also have down below the Insomnia Severity Index. And on the right is the Tobacco, Alcohol, and Substance Use Screen. So on the right here, this is an example of a medical document which authorizes the patient to order medical cannabis. It contains some information that's found on a prescription, such as the patient's date of birth and contact information, but not all of the elements of a typical prescription. It also states the number of grams of cannabis per day the patient is authorized to have and how long the authorization lasts for. And we typically authorize for 6 to 12 months at a time. Once we send the medical document to the distributor, and we're currently using medical cannabis by Shoppers Drug Mart for availability of a certain product, it takes at least 2 business days to process this. And the product we most often recommend is a CBD dominant cannabis oil that contains a ratio of 2 to 50 of THC to CBD. And there's no standard dosage, not like a typical medication. So to give you some perspective, our starting dose is approximately 0.1 mil. It's also measured in drops, so that works out to about 3 drops. And we follow the start low and go slow approach. So these are some, I want to introduce some of the patient education initiatives we've worked on, which are at a broader level than the education provided in each individual consultation. The Cannabis and Cancer brochure was originally developed in 2018 when cannabis became legalized, but we have just updated it last month. It is available on the Odette Cancer Center website and at the pharmacy and the patient education library called the Pearl. And as I discussed earlier, there are plenty of misconceptions out there. So we've seen firsthand that patients have been misled by endorsements by Rick Simpson or other miracle cures. So as of 2021, we're planning a social media strategy to have a presence where patients and the public are going for their information about cannabis. The infographics we are working on will help dispel some of the commonly encountered myths. We're also aiming to expand staff education. The base of the by physicians, admin, dietitians, social workers. Hopefully you can still hear me. It says internet connection unstable. Radiation therapy and pharmacy. It's important to inform all the staff about our program structure and any updates so that they're aware of how to appropriately direct patients. We also hold pharmacy staff education sessions quite regularly, about once per month. We found that this reinforcement is key to building confidence in our interactions with patients and ability to provide advice. Therefore, there's continually new evidence and new information that's available about cannabis, so there always seems to be new information to share. And at the top, we're always open to questions from any discipline about medical cannabis. And we often receive questions from social workers, oncologists, and various other healthcare workers. Carlo and I have set up an API rotation for PharmD students for the cannabis service, which has helped support it. It can be a steep learning curve of very unfamiliar territory for students, so we've created a reference manual to lay out the procedures. Through this rotation, the student is responsible for patient assessment, documentation, follow-up with support from the preceptor through daily debriefing. So now to take a deeper dive and prevent some of the data from our service. So we started collecting data about our service and flow of referrals to better understand our volume and have an accessible summary to inform future decisions. We're tracking the flow of referrals, including date referred, date consulted, and date discharged, patient age, sex, type of cancer, reasons for referral to us, whether or not the medical cannabis was recommended, and if it was started. Any reasons for not recommending medical cannabis, or the patient reported reasons for not taking it, or any other pertinent details relevant to the case were recorded in a comment box and categorized and summarized in our analysis. So we looked at the period from July 13th, 2020 to March 5th, 2021, which is a 34-week period. And July is when the service sort of picked up again, as there was a brief pause due to the pandemic, and it's been going strong ever since. During this time, we received a total of 96 referrals. We're tending to see more females referred than males. We're at about 65% female. And in terms of the age group, we do see a wide range. However, there's a notable peak in the 55 to 69-year-old age group, with majority of them being around 60 years of age. Similarly, the range of cancers is quite diverse, and it aligns with the population of cancers that we most commonly treat at Odette. So the numbers are all there. All right, so out of the 96 referrals, we recommended medical cannabis in 44 of them. Some of the reasons that medical cannabis was not recommended were that they required treatment with an alternate first-line therapy, there was a potential drug interaction or contraindication. Sometimes the patient just simply had a lack of indication or just required education. Some of them, it was the patient's choice not to continue going this route, and 7 of them, second, I can't actually see it, we're using it with recreational intent. So out of the 44 where we recommended cannabis, 4 of them already had a medical document, and the other 40, we had to prepare a medical document. What I find most interesting and what might be an area for further research is that out of the 40 that we obtained a medical document, 20 of them actually started medical cannabis and 18 did not, and 2 were lost to follow-up. So this sort of signals something, and we defined starting medical cannabis as taking it for more than 3 days. Referrals have been steadily increasing, and although it goes up and down, we're seeing consistent increases even when looking at our data for March so far. So about 1 per business day. As you can see here, most of our referrals are from physicians at 43%, and a good chunk are from our pharmacy team at about 34%. And our leading reasons for consultation are here. These are consistent with reasons for medical cannabis use that are reported in the literature for cancer patients. So pain, sleep, anxiety, inappetite, and nausea being the top reasons. There is an other category there, and the reasons for other include treatment of cancer, preventing chemotherapy side effects, arthralgias and myalgias, depressed mood, stress, itch, fatigue, or as a supplement. The product we most often recommend is a product with very low THC to minimize adverse effects. We do not ever recommend smoking, vaping, or edibles for their risk and their inconsistent effects. You'll notice that we almost exclusively use a single product, and this is a significant departure from current practice out there, where various products are often used for the patient, and you never really know what the patient is sort of confused between all the different products. It takes about 3 days before we can get to a consult, and sometimes we're working through a bit of a backlog because all of the steps do take significant time in addition to following up with current patients. So the focus for next steps should be improving efficiencies to streamline our processes while maintaining our standards of care. So I'll just briefly introduce my research project if I have a minute or so. So since our service is so new and to our knowledge, the first oncology-focused medical cannabis service in Canada, not much is known about the patient perspective on their experience. This, my master's project will be a qualitative research study containing a brief questionnaire with semi-structured interviews with patients who have accessed the cannabis consult service. I'm happy to announce that as of a couple days ago, we have 7 interviews completed, so we're on our way to obtaining our minimum number. And this is just a study overview. The study is titled Perceptions and Experiences of Cancer Patients Accessing a Pharmacist-Led Medical Cannabis Consultation Service in Toronto. My view or paradigm that I'm working in is post-positivism. So in this space, I'm trying to find out a truth, but I'm fully aware that the truth is shaped by various factors and can never be fully ascertained. And as such, I'm guided by realism, which is the ontology as I conduct the investigations. And the realist perspective, and I'm using LOA and Illings, will consider the dialogue's context, so having cancer or being seen by a pharmacist, in relation to its mechanism, which are common themes, and the outcomes. Our timeline is that we are still actively recruiting for a few more patients, but ultimately the goal is to complete all the interviews by the spring. So this is not Carlo with a hard hat, but I really want to depict all the scaffolding and work that has been, building this from the ground up and acknowledge that. So we do have some exciting news, and it's still in the works, but we hope to have dispensing on site at Odette Cancer Center Pharmacy, which will remove one of the barrier steps and complicated processes to ordering and registering. This is due to cannabis regulations that were amended at the end of December 2019 to allow for dispensing at a hospital. And this also helps to facilitate research, so stay tuned. I'm just ending with a brief comment on the pharmacist role. And here is the OCP's cannabis strategy, and it doesn't get any simpler than following this to have a better understanding of the pharmacist role. We strive to maintain our education and attend conferences that are going beyond the minimum cannabis modules wherever we can. And in the second pillar, pharmacists are in a position to provide direct care for patients using cannabis for medical purposes. And we would like to shift the paradigm that pharmacists are, not often the ones patients go to when they want to find information about medical cannabis. So we want to be seen as that trusted resource where patients and pharmacists are comfortable having these discussions. The third pillar really speaks to engaging in research and building our knowledge base. And the fourth is harm reduction, and this always applies, and especially with certain populations, cannabis use is associated with health risks, depending especially on how it's used. And the message I'm leaving you with here is that the relationship with the patient is at the crux of an effective cannabis consultation. It's imperative not to judge the patient for their desire to use medical cannabis or any strong beliefs they may have. And it makes sense on paper, but I'm telling you, it can be a challenge. We may not even realize that we are applying our biases, and these can get in the way of building a trusting relationship. At the same time, it's important to manage the patient's expectations for medical cannabis. Inform them it's not an evidence-based therapy. We cannot guarantee it'll work, but we can monitor their response and make recommendations about safe use. I'm just going to thank my supervisor, Carlo, as well as the first 3 API students who made the clinical service possible, and for Annalise for inviting me to present. And hopefully we have a few minutes for questions.
Thanks, Maria. And yeah, on behalf of Zubin, Lisa Dolovich, and I, we're really thrilled to have you and Jessica present with us today. I think it's a great opportunity to showcase both of the important research that you two are doing. I'll let any questions trickle in. I know we are coming up close to the end of our time, but Maria, I was particularly curious about the slide where 20 of the 40, so half of the patients actually decided to go through with the medical documentation and actually getting cannabis dispensed. Really curious on your thoughts about that and if that will come up during some of the interviews you're conducting. Because I think it also ties in maybe a kind of secondary question is that stigma you were talking about and how that lands both on the pharmacist, but also the patient's own perceptions of using cannabis regularly.
Yes, you bring up a good point. So the stigma is not just with health professionals and pharmacists, it's also among patients, and they can often receive this package and it looks quite scary to them. It's like very foreign, unfamiliar, doesn't really look like a typical prescription. There's all these warning labels on it, THC stop signs on it. And so I think that does have something to do with it. Oftentimes, this therapy is so new that we're doing so many things at the same time, whether it's somebody has pain from their cancer and they're undergoing treatment, their pain improves, and then they no longer, because it takes so long to get access to the cannabis, by the time they receive it, they've already gone through several treatments, they're feeling better, and they decide not to use it. So the reasons are most commonly those reasons, and also quite a number of them were citing cost as one of the reasons.
Yeah, really, really fascinating. It'd be so neat to see what emerges with the interviews and analysis that you complete. And also just congratulations to you and Carlo for really getting this off the ground at Sunnybrook. I think it stands to pave a very maybe clear path for other people wishing to follow in this sort of trajectory, and also incorporating API students, which I think is really important to make sure that, you know, future leaders such as yourself is very informed about these kinds of things.
Right, thank you.
I don't see any questions in the chat box, but I hope that everyone online that was a fruitful conversation, and I'm sure Maria and Jessica would be more than happy if you followed up with either of them. I would like to thank you both again, Jessica and Maria, for presenting with us today. Such fantastic work and so exciting to see it coming out of LDFP. Just a little plug for our next CPE sessions. We have 2 coming up, so May 6th and May 13th, both which will be quite interesting. And with that being said, I'm going to turn it over to Zubin, who's going to close us out for the day. Thank you again.
Thanks, Annalise.
Thank you, Annalise, Maria, and Jessica for a really interesting series of presentations that got a lot of us thinking about things that perhaps we hadn't thought about before. One of the things that perhaps some of you are thinking about that you haven't thought about before is actually the MSc PHM program. Jessica and Maria are our first 2 students in the program, and as you can see, they are off to a great start in terms of being future leaders, clinicians, and academics. For those of you who are interested in learning more about the MSc PHM program, I'd encourage you to consult the faculty website or speak to the program leads, Beth Sproul or Lee Dupuis. In the meantime, thank you all very much for joining us today. Best wishes for ongoing and future success for Maria and Jessica. This is not the last time we're going to hear from them, I'm sure. And of course, a big thanks to Annalise for organizing everything so beautifully today. Thank you all very much. Good evening.